All right, well, I think we'll get started. So, welcome everybody. Today's panel, prior authorization and trust in U.S. healthcare. It's part of the Hopkins Business of Health Initiative's monthly webinar series, Conversations on the Business of Health. I'm Dan Polsky, director of the Hopkins Business of Health Initiative, or HBHI. HBHI is a Hopkins-wide initiative bringing together scholars from across the university where we all share a mission to advance health through an affordable and accessible high-value health system. And our focus is on the role of business and incentives in advancing health, which is so this topic today is right over the plate for us here at HBHI. So with that as a welcome, I'll turn the proceedings over to our moderators and HBHI experts. And just to say briefly that the moderators who have organized the panel have been talking about doing this for, I don't know, about 9 months already. So we're really excited to be able to do this here at this important time for U.S. healthcare. So I'd like to welcome Amit Jain, Associate Professor, Johns Hopkins University School of Medicine, and Joanne Kennan, journalist in residence from the Bloomberg School of Public Health. Thank you both, and I'll turn it over to you.
Thanks, Dan. Good morning, everybody. My name is Amit Jain. As a practicing clinician, I can attest to the fact that there are few topics that bring as much angst to clinicians as prior authorization. Today, we have a really exciting webinar with some really phenomenal folks. JP Holland, who is the CEO of the Johns Hopkins Health Plans, Ceci Connolly, who is the CEO and president of Alliance of Community Health Plans, and Ravi Gupta, who is an internist, a practicing clinician, and a health services researcher, who is going to be providing their experiences around this topic. You know, prior authorization is something that is frequently used as a way to check care and check the appropriateness of care that's being delivered. There's rates as high as 33% that have been reported in terms of denials. It really begs the question, is this the best use of way to check appropriateness of care, or should we be using something else? We're going to be delving into these conversations today and really kind of get into some of the exciting themes around this. So thank you all for joining, and I'm going to turn it over to Joanne.
Okay, and you know, we're trying to get at, you know, America has a problem of both. We have overtreatment and undertreatment. We have both. And you know, it's like the three bears. How do we get to the chair that the care that fits right, sort of the goal. So I want to get all three speakers into this conversation quickly with a sort of starter question to bring everybody into the discussion. They've been warned they only have a minute. I'm not going to time them, but just a brief overview from all of us, and I'll call on you. The first question is, like, we added the word trust to this. You know, originally it was just a seminar on a webinar on pre-authorization, and then we added the word trust because we are in such a period of corrosive distrust in basically every aspect of healthcare and public health. And this people feeling, whether or not accurately, that they're not getting what they need and are entitled to is exacerbating that trust. So just start off with, like, is each of you briefly, is the current system of prior authorization, you know, the right way to go about things and just needs a little tinkering, or do we need to really rethink how we're doing this? I'm going to start with Ravi.
Yeah, thanks so much, Joanne, and thank you for the opportunity to be on this panel. I think about prior authorization wearing a couple of different hats, and as Amit said, I'm an internist. I practice primary care here at Johns Hopkins, and the other hat that I wear is that I research prior authorization. And so I think about it as a policy issue. I think about the trade-offs that are associated with prior authorization. And the reason I really love the title that you all selected for this and tried to make trust a central part of it is because I see it in my clinic. You know, when I want to prescribe a certain medication or a particular service, and I don't know if it's going to be covered by my patient's insurance, and it varies between different insurance plans, I can sense that the patient who has trust in me to be able to deliver that care to them, it's out of my hands. And so I think that decision point in that moment, I can sense that it does impact the trust that the patient has in me as a clinician and in the health system overall. And then to say more broadly about prior authorization, we'll talk about this, but given all the trade-offs, I think that prior authorization is here to stay. And the question becomes in the clinic and as a policy issue and thinking about the costs associated with prior authorization, what are the ways in which we can improve the process of prior authorization? How can we make it more efficient? How can we reduce the administrative burden associated with prior authorization for clinicians, patients, and on the payer side?
James, JP.
Sure. Before I jump into the specific, maybe I'll provide a little bit of context on our organization, which could be helpful. So we're a $3.5 billion provider-sponsored health plan, community-based, focusing on safety net populations and government programs. We're affiliated with Johns Hopkins, but we have a national network, and about a third of our care goes through Johns Hopkins affiliated providers. So when we think about our role as a community-sponsored plan, we are stewards of the care and the members that we serve, but we're also stewards of the state and federal dollars, and there's a limited pool of dollars that we have to deal with. And that's sort of where authorizations come into play. At the end of the day, we need to ensure, and we're obligated to ensure, evidence-based and appropriate care. So we collectively want to have the best care delivered for our members while recognizing that there is administrative burden associated with authorization processes. So how can we affect a more transparent, easier to do business with authorization process while maintaining appropriate oversight? So that's sort of the lens that we look through as a community-based health plan, and how we can affect effective change and be a leader through this process.
Ceci.
First, I want to say thank you, Joanne, Amit, and of course, HBHI for this terrific and super important conversation. I suspect through the course of this, you will hear JP and I agreeing vehemently on any number of things because we do come from a similar perspective. Our members at the Alliance of Community Health Plans are all not-for-profit, provider-aligned, community-based health plans. So the reason that I want to just say that at the start is that I'm not entirely certain that we have to have prior auth in the future if we see providers and plans coming together in a coordinated, integrated fashion, the way our members do, really agreeing upfront on what are the proper protocols, procedures, et cetera. And I'm happy to talk a lot more about this in today's webinar, but specifically, Joanne, to your question on trust, I can understand why prior auth friction can certainly add to mistrust or distrust in the healthcare system. And so certainly it's something that we need to take seriously and reduce that friction, reduce the frustration where we're finding it. But let me just say, sadly today, I think we have major trust issues in our entire society. And so the trust problem right now today is just enormous and overwhelming. But yes, healthcare's got to do its part to really improve that.
No, I mean, maybe sports, maybe the one thing we find, and I'm not even certain about that, but pretty much everything else, there's some kind of
maybe
right, really corrosive, really profoundly corrosive distress. But I've also had physicians tell me, if I say to a patient, that's not the right care for you, I don't recommend that. Yeah, I know your friend, your sister-in-law's next door neighbor's uncle's, ex-wife told you to get it. But the physician saying, no, the patient is not hearing, oh, my physician doesn't think this is right for me. They're hearing, oh, the insurance company doesn't want me to have it, and my doctor can't recommend it. And that's, that's something that physicians are experiencing. And I mean, check it. Your turn. Go take the next round of questions.
Yeah, I think all three of you have hit on the point that while prior authorization hopes to answer the question about appropriateness of care, there's the reality that a lot of times that appropriateness of care is subjective. A good example of this is that clinicians rarely appeal denials, but when they do, almost 80% of these denials are overturned. So that begs the question, why were these requests denied in the first place? Was it inappropriate care that was denied, or was it a process that was broken that resulted in the denial that eventually got overturned. So I guess with that in mind, I guess the question is for Ravi, do we know if there's evidence from scientific literature that prior authorization actually reduces low value care? Because clearly all health plans are using this as a tool, but is this a tool that actually reduces low value care? What's the evidence?
Yeah, thanks, Amit. I think that's the central question that needs to be answered. I think the way that I think about prior authorization is that it's a managed care technique that's been around for decades, since the 1980s. It's obviously picked up a lot in the last 10, 15 years, especially with the growth of Medicare Advantage as a utilization management tool. And the idea being that in theory, prior authorization is to reduce low value care, right? We want to reduce waste. We want to avoid patient harm associated with care that shouldn't have been delivered in the first place, that can lead to a lot of follow-on tests and diagnostics that can be harmful to the patient. And so I think that similar to many other tools like high deductible health plans or other forms of patient cost sharing, prior authorization ultimately ends up being a bit of a blunt instrument in that it does reduce both inappropriate and appropriate care as far as we know. But I think this is also a central question that requires a lot more research. It just points to the fact that it's really hard to even figure out what is low value care. There's some definitions, there's some services, but they differ based on the context. And so it's difficult to identify what's low value care. And then it's even more difficult to identify whether prior authorization is actually targeting low value care or low value services appropriately. And so I think from my understanding of the field, there's still limited evidence on which services specifically are being targeted with prior authorization. I think but it is a blunt instrument in that all services are reduced. And one thing I'll just say, and then I'll pass it on. But we published a paper last year where we looked at the services or the differences between different Medicare Advantage insurers that require prior authorization. And the greatest amount of consensus between the different insurers was on the most expensive services. And so what we do know is that prior authorization is when there is great uniformity, it's on the most expensive services. And then the least amount of consensus was just on other services that aren't as expensive. And so prior authorization is used to target the most expensive services, and it ultimately, I think, affects both appropriate and inappropriate care.
JP, can you give any examples of ways in which your health plan has modified or revamped or changed? I mean, are things you are doing to make it a better process as I'm trying to remember, you've been there 5 years. Is that what you told us? I may have forgotten. But I mean, there's attention on this, there's consumer dissatisfaction about this. Are you using the same systems you used a couple of years ago, and how are they better?
Well, we're not using the same systems. We're really advancing our technology and processes within Johns Hopkins Health Plans. We've made a lot of progress on that front, frankly. So I think, at the end of the day, we view prior authorizations differently than perhaps some national plans and non-community-based plans. It is a fiduciary responsibility we have. Our state and federal customers expect us to ensure compliance with medical necessity requirements. And so what can we do to reduce administrative burden in that process? There's a few things that we've done to optimize that. We've automated and streamlined some of utilization management. So that's, for example, we piloted an automated authorization summary process within Epic to help reviewers quickly locate information in the medical records, kind of reducing the back and forth of requests with authorization. And we're now collaborating with Epic to integrate lab and imaging reports to further streamline the process. So that sort of automation to put less clinical hands needing to shepherd the process, I think will be extraordinarily beneficial. And interestingly, Johns Hopkins Health Plans is on the forefront of that, specifically with Epic and Payer Platform. Internally, from a process perspective, we're evaluating PA necessity. So we're continuously reviewing whether it's necessary and removing unnecessary authorizations and trying to only focus on the services where a coverage determination is complex or pre-approval benefits the provider by confirming that claim eligibility. The partnership that was discussed earlier is critically important. So having, gold carding processes and working with select network providers to eliminate the need for prior auths and services where strong practice patterns and controls are in place. The other thing that you'll hear a lot from payers is electronic authorization solutions. So moving away from faxing, right? It's 2025. We shouldn't have all this paperwork and faxes. We've integrated these electronic solutions into our workflows and our provider workflows. So that helps us cut response time and reduce errors within the health plan. Bottom line is, I think if we focus on technology and collaboration and reducing unnecessary authorizations, we can make prior authorizations more efficient, transparent, and patient-centered.
JP, I love that. And I think you offered a lot of solutions, which is really wonderful. And I'd love to kind of dive deeper into each of these. But, when I put my hat on as a surgeon, there's nothing that irritates me than prior authorization on a weekly basis, because I feel like I'm on the side trying to take care of patients, trying to get them the care they need. There are people in my office. My mock Danielle is on here, I think, on the attendee list, and she's figuring out what's wasteful and what's not. And I think one way to do that is to have transparency. And one of the things that frustrates clinicians is lack of transparency on the process and knowing what criteria need to be met. So maybe this is really a question for you, Ceci and JP, both of you. What can we do to increase transparency where the clinicians know what criteria need to be met? There's less administrative burden. And what do you recommend should be done? And why hasn't it already been done to increase transparency around this?
Sure, I have some thoughts, but Ceci, please.
Sure, happy to. And I'm so glad that JP mentioned the problem of faxing in the year 2025 so that I don't have to spend too much time on that soapbox. But truly, we all need to adopt and embrace technology these days that can improve many of these things. Talking about paperwork, for instance, the use of Epic. Epic sells some very expensive products right now to health plans, and that's a challenge for our community health plans that are nonprofit on small margins. But they're making those investments. I think about a place like Geisinger, that is using technology to get to yes very, very rapidly for the vast majority of any of its prior auth requests. And much of it is offering decision support tools and bundled authorizations. And those sorts of decisions now are just automated to yes. Geisinger's system will also this is just a great example. It will spot in the electronic information flow if there's missing information from the clinicians, and it's able to ping those clinicians and say, gosh, you haven't provided this and that. If you fill that out, then boom, again, we're getting to the authorization immediately in real time. But we do often find at our health plans that clinicians are not providing some of the basic information. On prescriptions, yes, the patient has already tried this therapy, and this is now why we're proposing to go to this third option. But if the physician doesn't indicate that somewhere, the health plan is wondering, gosh, why didn't you try number 1 and number 2 first, which work for most people? So it's got to be a real partnership here. I take great hope and encouragement from, again, our members and plans such as Hopkins, where it is much more of a collaboration with the clinician. I'll give you just one more quick example. Out in Michigan, Health Alliance Plan, HAP, which is part of the Henry Ford system, they have got over 3,000 clinicians that are exempt from a slew of prior auth steps because they have been good, strong, high performers. They've got great outcomes. They're following a set of recommended protocols that everyone had agreed to in advance. They're designing these things together jointly so that everyone's in agreement about what is the evidence telling us makes the most sense in the vast majority of these instances. There's always going to be the rare case where you've got to go and have some sort of a communication about, gosh, this is unusual. It doesn't fit the typical standard of care. But so many of these things, they can get to yes, and they are. So I think it's really important to delineate which insurers are really causing the friction and why. And dare I say, in many instances, it's because they answer to shareholders and they've got to record profit margins that candidly community health plans don't.
You just raised something that I was going to, but sometimes called gold carding, the exempting people who have good records, or at least maybe either exempting them completely or reducing the amount of pre-authorization. I'm going to ask Ravi that in a second, but I also wanted to, when we spoke before the webinar, you brought up this issue of that there was an extraordinary high percentages of among your plans of the denials did have to do with, like, they didn't fill out the form right. And my question to you was, can you make the form simpler? So is there something, I've yet to meet a physician who, introduces himself, I'm Charlie and I love my EHR. Is there something, is anyone tackling that issue? If it's so, I mean, doctors are smart people. Like, if they can't click the right box, there's might be something wrong with the box. So, Ceci, you talk about this second, and then I want to go to Ravi right away on this concept of gold carding, because I'm pretty sure that Texas now mandates it. And but let Ceci talk, and then we'll switch to gold carding.
Well, I think in the instance of most of our plans, as I've said, it's because they're co-designing so many of the protocols up front. So they're already in agreement about what should be done in any number of these cases, and they're identifying what's appropriate and what's low value. But yes, I am certain that we can continue to innovate the technology and call on the Epics and Cerners and others of the world to come in on this partnership. We're going to see more happening with interoperability requirements, transparency requirements. Also, some of this is generational. I had a primary care physician in Washington, D.C., who told me a long time ago, if she had to use an electronic medical record, she was going to retire. And so I'd go in for my annual physical, and she had a sheaf of papers that was 3 inches high, and she'd be flipping through it, and coffee would be dripping on it. And it was slightly terrifying, to tell you the truth. So some of it's also, generational, and we need to continue to test and embrace and improve these things for everybody's benefit. I think it's possible for sure. I also, we started this conversation kind of along the lines of, well, does prior auth actually reduce low value care? Let me just give two quick examples, and they have to do with preventing people from going to the emergency department for any number of things, or hospitalizations. Again, because working with the clinician, you might be able to save that trip to the ED. You might be able to get now hospital at home, which is a terrific option. So those are some of the ways in which this partnership and this technology can really benefit the patient.
Hey, Ravi, just the issue of the good physician, the physician who has the track record of a high percentage of what they recommend is in fact the right level of care.
Yeah.
How successful are these gold card programs, and is that something that all states should be moving toward? I think it is a requirement in Texas. Someone can
Yeah,
correct
they
me if I'm
passed
wrong.
some. Yeah, so Texas passed some legislation around gold carding, as did a number of other states actually. And I have to admit, when I first heard about gold carding, I was pretty excited about it, because I thought, oh, what a great solution to try to expedite and make more efficient prior authorization for the docs that are doing it right. But I also have to admit that I'm a little bit less bullish on it now for a couple of different reasons. One is I haven't found really any studies yet, or any good evidence about whether gold carding works, whether it ultimately saves costs, reduce administrative burden for clinicians. I think the jury is out on how effective gold carding can be. And I think the only thing that I have seen is some surveys, right? That satisfaction improves somewhat, doesn't necessarily reduce costs because the task of actually identifying the physicians in aggregate who have met some threshold of, having some prior authorization approvals is itself cumbersome, and so may not actually end up reducing costs overall for the plan.
Is that process done through mostly an AI search, or I mean, how does the plan decide you get the gold card?
I actually don't know the answer to that. Maybe JP or Ceci know about that more, but I don't know how they're able to identify
So it's
those clinicians.
typically based on a pattern of good behavior. So very few things being rejected, 95% approval rate, and, good practices in place to ensure that clinical criteria are met. And then typically there's some degree of oversight after that's awarded. The other piece of the question is it sort of all services that are gold carded or most services? So for example, a PCP could have the majority of the services they deliver gold carded, but perhaps high cost imaging still gets reviewed. So that sort of depends on the situation. But I agree with Ravi, it probably isn't much of a cost saving effort. It's more about administrative reduction, trying to be better partners with providers that are really adhering to clinical criteria.
JP, I'm going to ask you a clarifying question on that. We talk a lot about value being defined as quality over cost, appropriateness, equity, all those multiplied together. Now, it seems to me a lot of prior authorization efforts do a great job hoping to reduce cost for the health plan in order for the health plan to be better stewards of the money that they have. But it's passing that cost on in some ways to the clinician practices by increasing administrative work. And then it's also not necessarily targeting quality, which is the other part of the equation, right? In other words, how do you know that the procedures you have in place are actually not only reducing cost and not just passing the cost on to someone else, and also actually improving quality of care that's being delivered? How do you kind of follow that? What are your key process indicators?
Yeah, so when we think about performance metrics, ultimately our approach to prior authorization is rooted in ensuring appropriate high quality care rather than achieving arbitrary approval or denial rating targets. So to that end, we track approval and denial rates and we analyze trends, but we do not set targets for approval or denial rates. And the focus is on the consistent application of criteria that supports evidence-based care. We also closely monitor prior auth response times to minimize delays and ensure patients get timely care. And we review, as was mentioned earlier, appeal rates and outcomes. So high appeal rates can indicate the need for process improvements. And so we use this information to help refine how we apply criteria and make sure that there is transparency in what the needs are to get authorizations approved. We also look at utilization patterns to review service use trends and identify when prior auth should be removed or certain services when guardrails need to ensure better medical necessity. Our perspective is by proactively adjusting prior auth requirements based on real world data, we strike the right balance between cost control and patient care.
I mean, I want to bring in a question from the chat or the Q&A. People should be not using chat; they should go into Q&A. Like, are we? Is there more that can be done since there really isn't a universal agreement on what is high value, what is low value, and also there's individual patient variation. Is there more that can be done? Many of the specialty societies do have some kind of, not a, I don't want, just sort of an evaluation of this is what we should be doing and this is what we should be doing less. Is how much is going on between the plan's criteria and the specialty organizations? Is that happening? And if so, is it sort of the foundation for a better definition, or is it still shifting and not necessarily as grounded as the science as plans want to see it? And who wants to take that? We've sort of.
I'm happy to start because I certainly know that I talk, for instance, to a number of the special society leaders about these things. I know that our plans are certainly plugged in. There's great variation, right? None of these questions has a simple black and white answer to them. So it varies by specialty, by plan, et cetera. Again, I would come back to our member plans. They'll tend to be obviously connecting with societies. They're looking at a lot of data, whether it's FDA data relating to therapies that are going on to the market and looking at clinical trial data, et cetera, et cetera. But then really bringing it into home. So to your point, Joanne, it's probably the foundation. It's the really great starting point. But then they're also going to bring it in and they're going to in their care coordination or integrated model, they're going to look at, what has been their experience with something. Where are they in terms of innovation? I mentioned hospital at home, for instance. Not every organization is offering that today, but where it is an option, that's something that they can be doing. Just to give you a couple of little stats here, and I'll go back for a minute because I have some notes on Geisinger, which now using its prior authorization portal. So really kind of plugging into the technology, and they've got between 90 and 100% of their clinicians that are using it in areas such as condition management, home health, and outpatient rehab. So it's not everything, but those are kind of big, important targets. And they have seen their turnaround times come down from almost 2 days in 2022 to 0.67 days in 2023 to 0.36 days. That's a matter of hours in 2024. And at the same time, each of those years, the volume running through the portal has climbed exponentially. So this is really a pretty good news story where you have clinicians now taking advantage of this portal, no paperwork, no faxes. Everybody knows and agrees what the protocols are. And as a result, the limited number of prior auths that they are looking at, it's less than half a day to get to a response. That's pretty darn good, I would say.
Yes, and it's also, we've been looking at Geisinger as a sort of beacon for on many, many aspects of healthcare for, 25 years now. And the rest of the country still doesn't look like Geisinger, right? It's the outlier on the good side, an outlier. It's not the only one, but it's still what they do is not the norm. And lots of things that people have written many, many articles about. We should all do this like Geisinger, and it hasn't happened. So it's not that that's not sort of a beacon of sort of, okay, this is how it could be done, but it is not how it currently is done in for the majority of patients. So, Amit?
Yeah, I'd like to talk about AI for a minute. We have all seen artificial intelligence and natural language processing be an incredible asset in many areas, both in medicine and outside of medicine. So, for instance, these days we use a lot of ambient listening softwares to scribe for us. In the foreseeable future, we should be able to kind of have that information automatically be extracted and tagged and flagged to say, well, this is the stuff that's important for JP's plan and Ceci's plan and so on. And this, for this patient's care, check, it automatically kind of pulls that data. But AI, we know in the literature, or at least in the news, is also being used to automatically deny care. I forget the study, but there was a 0.3-second denial sequencing that was taking place at a major health plan. And it was just, automatically AI would look through the notes and just deny a ton of care. So
without a human double checking it, really. It was
that's right.
A batch denial.
That's right. So my question is, how do we use these technologies responsibly, and how do we use them as a beacon for actually driving high quality and high value care, and not just the cost containment, which frankly, a lot of clinicians believe that's how they're being used currently. So I would love.
So I want to jump right in here because first of all, there has been some outlier behavior, and I think it's up to clinicians and the industry and frankly regulators to look at that outlier behavior and do something about it. That's number one. I am not going to dispute that in any way, shape, or form. That's an issue that really needs some serious scrutiny and probably some activity by regulators. But it also means that providers need to think twice about which plans they're going to partner with in this healthcare system, because you really do want to find good partners so that coverage and care is coming together and making sense. So that's number one. I feel very strongly about it, as you can see. But there's just sort of this broad brush today that frankly we have to be a little bit more sophisticated on this scary notion of AI. There's a computer dictating your medical care. Let's be honest. Algorithms, basic algorithms have been used in medicine and at health plans for many, many, many years, typically back office, typically administrative functions. It's about efficiency. So I don't think we want to scare people by all of a sudden suggesting, oh my God, it's a computer that's deciding what your mother's care is going to be. We need to be very, very clear. There's the next level of artificial intelligence, much more sophisticated, that we as a country we need to grapple with that because the technology is there, and we need leadership. We need guardrails. We need a lot of smart thinkers on this. But for the most part, plans today are still really using this basic algorithms around efficiency, pooling together information, et cetera.
What about the next question? To JP, practice costs are rising. Physicians' reimbursement is often not rising very much. And then they're seeing this as a extra administrative cost that becomes a burden on them. I mean, what is the perspective from the plan? And if this is what your physicians and providers are experiencing, what are potential ways of closing that gap?
Yeah, happy to. If you don't mind, I might get a twofer in here and close
Sure.
out the previous question. So
The AI question you should weigh in on, yeah.
we firmly believe that AI or automation shouldn't be denying care for patients. Automation should only be used to expedite processes, give quicker electronic approvals of services, and try to reduce administrative burden and speed up determinations. A human is the only one who should be reviewing medical necessity and making a determination. And that's something we feel very strongly about and apply in our own organization. But answering your question about healthcare costs, we play a critical role in balancing affordability and access, especially in safety net programs. So we're responsible for ensuring healthcare remains both high quality and financially sustainable. There's a limited pool of dollars that we're giving to support these members, and we need to stretch it as far as possible for our employers, government agencies, and individual consumers who might have some degree of cost sharing. So we do this through a few ways. One, as Ravi indicated, value-based care and value-based agreements. So working with providers to yield value while maintaining access to quality care. We're ensuring claims are only paid for covered services. We act as fiduciaries, ensuring premiums are used to pay for services that are medically necessary and cost-effective and not experimental or cosmetic. That's sort of, not the fun part sometimes from a provider perspective, but it's a legal obligation we have in the administration of our plans. We apply prior authorization for high-cost discretionary services. It's, helped to prevent unexpected financial liabilities for members and providers by making these determinations before services are rendered. And we are combating fraud, waste, and abuse. We're monitoring utilization patterns. We're reducing unnecessary expenditures that drive up healthcare costs for everyone. But ultimately, our job is to make sure that patients are getting the care that they need at the right time in the right setting while keeping healthcare costs affordable for everyone.
I have a question for you. As a clinician, you understand that we oftentimes are very algorithmic. So in other words, we think about a clinical scenario, we think about kind of the algorithm that it triggers in your mind, and you kind of walk the patient through that algorithm to their final care process. Now, if we had access to kind of behind the curtain on what the plans are doing with prior authorization in terms of their algorithm they're using to approve or delay or deny, how would that change clinical behavior? So in other words, do you think clinicians would more likely game the system and just click the right boxes to get the patient to that approval, which currently is not necessarily accessible? Or do you think clinicians would be better stewards of that care? Would love to hear your thoughts as a fellow clinician.
Yeah, I think that's a great question. I've actually, so um, at Hopkins with Epic and the electronic health record, there's been a few occasions where I was trying to prescribe, I think it was an MRI or maybe some sort of, relatively expensive imaging, and I did have to walk through a number of those steps, and there were subsequent questions about what the condition was, but give more information about the context. And even though in my mind I felt like the MRI or whatever that image was the correct test for that patient, because I was accurately going through their flow diagram, I received the response that that I shouldn't, that it wouldn't be covered, but I shouldn't order the MRI. And I could tell which specific point in that diagram I could have changed the response to get to the yes. To answer your question, what I took from that, and now that I'm reflecting on it, is that I think most clinicians would answer those questions knowing what's happening behind the curtain or what's happening under the hood, truthfully to ultimately decide whether or not to prescribe, whether it's the medication or the service. One thing I did want to just follow up on as well that Ceci and JP were talking about is that there may be plans that Geisinger, for example, as a health system is held up as a success story when it comes to this, or there might be individual plans that are tackling some of these issues in a way that we might want. But as a clinician, I'm also dealing with a ton of different plans, and each plan has different requirements for the same service. We get emails. So GLP-1s, for example, are the prime medication right now for which prior authorization is required. Very expensive, makes sense. We receive emails about here are the 5 or 6 different insurers that you're working with at this clinic, and here are the different requirements that each of those insurers have put forth for the GLP-1s. What are the conditions, whether it's for diabetes, whether it's for obesity, and that's just one medication. It's GLP-1s, which is a big portion of it, but having to navigate different plans requirements by itself also creates a lot of administrative burden. So at the clinic that I work at, we have an outstanding prior authorization team, which was only established in the last 2 years, just as there's been an increase in the volume of prior authorization. And so it's helpful to have that team, but it's also a reflection of the fact that there is a great deal of administrative burden associated with prior authorization, and that there is variation between different plans. And I'll stop there, but we talk
Well,
about
that's a phenomenal point though, because Ceci, you have probably hundreds of plans as part of your alliance. You can give us the exact number, and JP, you have at least I know 6 different businesses that you own that are part of your health plans. So how do you bring cohesion among the different plans and the criteria? Because the reality is a lot of times these things are being outsourced. They are being outsourced to a third party or a third party vendor who doesn't have any native embedding to the health plan, and you kind of have to go through a third party to kind of get these things approved. So how do you create cohesion among all these different businesses or different plans that you're administrating with different populations and so on?
And before you answer, there's a really similar or related and excellent question in the chat that gets it to some of the same points. So let's consolidate. I'm just going to read it literally because it's quite good. As the manager of a prior authorization department at a pediatric rehabilitation hospital, I mean, we're talking sick kids, right? I find it extremely challenging to navigate the vast differences in prior authorization requirements, expectations, and practices from payer to payer for the similar classification of services. The extensive challenges make it hard to believe that payer practices are not primarily stakeholder focused. How do payers plan to become more cohesive in the handling of common prior authorization requirements for more services to improve the care that patients are receiving? So add that on to the question before you. Who wants to take the pile on questions there first?
I'll take a stab at it. So when I think about medical necessity criteria across payers, certainly I don't personally have control over that at other organizations, but I'd say as an industry, there's typically a lot more similarity than differences. So the criteria that's being used is largely the same, 99% the same. It's the application of that criteria that can sometimes be different. The processes that must be followed by providers, the interpretation of that criteria, especially by larger for-profit shareholder organizations. And so what can we do as an individual health plan? Well, one, we can sort of collaborate with other organizations through associations like Ceci's on the effective application of that criteria in a consistent manner, some consistency in some of the governance and rules. But then within our own processes, providing greater transparency through the prior authorization process, us making sure that providers and patients understand the process clearly, which we hope would lead to better outcomes and fewer delays in care. Some of that is, the electronic prior auths that we were talking about, but being able to provide real-time information at the point of submission and throughout the process, including immediate feedback on why a criteria might or might not have been met, so it can be responded to quickly. Providing transparency tools. We have an interactive prior auth tool that allows providers to check requirements and access links to the medical policies to ensure that they have the same coverage criteria that physicians would have when doing the medical necessity reviews, and making sure that we're enhancing usability. We're exploring solutions in the market to try to improve that accessibility of prior auth information, making the process easier for all stakeholders. At the end of the day, we want to make the prior auth criteria clear, accessible, and aligned with clinical guidelines so that we, in our role as a health plan, can reduce frustration and improve care coordination.
I certainly agree with everything that JP mentioned there, and I understand the great desire for cohesion and agree with it. And I can very much sympathize with the role of so many clinical teams that are encountering different requirements and decisions from health plans. I completely understand that. And especially when we're talking about something of a new or emerging therapy, GLP-1s very well established for diabetes, and I'd be surprised if there's much variation there because that evidence is strong and been there for a very, very long time. But thinking about some of these new potential indications, including obesity, I think much more clinical study needs to be done. So it doesn't surprise me that you may have some payers with different criteria right now, as everybody's really trying to land on which patients that's most appropriate for, who's going to be able to stay on the therapy as needed. Right now, they say it should be for a lifetime. I'll give you another very good specific example out at Sanford Health Plan, where they are able to use prior auth, really looking at some of these very high-end pharmaceuticals. So when you think about cell and gene therapies, one example, spinal muscular atrophy, SNA, very, very devastating, lethal condition. And there is, in fact, a therapy for that. It's known as Zolgensma, and it's over $2 million for that therapy. Well, what Sanford discovered was that there were some physicians that were prescribing the Zolgensma for $2 million, but not for the patients that actually have the particular gene mutation that will qualify them and make that therapy effective. So imagine in that instance, if you're giving a patient hope where they don't fit the criteria. And then second of all, you go and spend $2 million. I mean, JP has mentioned more than once today, plans have the fiduciary responsibility. There's a premium dollar, and the health plan has to make sure that that premium dollar is going to be spent wisely. As much as there's frustration about prior authorization, there's an awful lot of frustration about the cost of healthcare, and that includes premiums, and it includes co-payments and deductibles and everything else. So again, these are very, very broad, nettlesome problems that we have across our healthcare system. We certainly at ACHP, we do try to bring our members together. We bring together chief medical officers, pharmacy leaders, et cetera, to share these best practices, to try to get, closer to this notion of cohesion. But we live in a society with a free market. And so people like to shop around for these things. That's just the nature of our country's system.
Just building on that, Ceci, I think what you hit on is the pace of medical innovation drives up healthcare cost among many other inflationary pressures on healthcare costs. And this is no surprise. Our costs are really, unrelenting and out of control for many reasons, and that's a different webinar. I guess my question is, where do the plans set the line of trying to figure out that cost containment piece, but at the same time, well, maybe it is high quality care that's just more costly. So it's still high value care. A good example is, I'm a spine surgeon. I do a lot of complex pediatric scoliosis surgery. And a lot of times that care is very expensive and it requires authorization and gets denied. And then I have to show x-rays or send clinical pictures and say, okay, look, this is going to change the kid's quality of life or trajectory of life. And it gets approved eventually. But the point is, yes, it is high cost care, but it's high value care because it's high quality, high cost. So how do you kind of set the line of trying to approve that while kind of getting rid of the stuff that probably ought to be controlled?
Well, I'm going to make a little observation. With something that sophisticated and that high cost, I don't think it's unreasonable that there's a little bit more discussion and back and forth and thought that goes into that decision before it is actually made. That kind of seems reasonable and commonsensical to me when it is that super expensive and complicated. But, really what we need to do is eliminate so much of the prior auth that's the very basic stuff. And those are the examples that I've tried to kind of signal today. The cost of prescription drugs, if we don't get a handle on that, it's just going to start bankrupting, in particular, the nonprofit community health plans. And then our nation is going to be left with a single payer. And that single payer is not going to be the government, by the way. So we as a society, again, and policymakers need to really think hard about the healthcare system that we want to have in this country. What are the different incentives, disincentives for certain behavior? I think that our plans really do put a focus on quality. They're among the 4- and 5-star plans rated every single year across the country. So they do. But I'm not sharing any secret when I tell you that many of them are struggling today and they're being crushed by a couple of national for-profit players that frankly operate a little bit differently than an organization that is based in a community. And so we're going to need to come to grips with that, I think, as a society.
Just that, we began this conversation by talking about how we had, we plan these webinars months in advance, or at least the topic. We didn't book you that many months in advance. And it was long before, it was months before the United Healthcare killing. And if anybody didn't think that there was a crisis of trust, I mean, boy, did we see it then, right? I mean, we saw the alleged murderer treated as a folk hero, all that stuff. We all went through that. It seemed as recently as December, and we're only in February now, that something had to be done. That it was that the public was fed up, that the system was broken, and that was we're talking about the for-profits, a handful of large insurers. And yet it's hard. And then that conversation was gone. That this has to change, and it's certain to change. I mean, I'm reporting around it at the time. This is the change moment, and nothing seems to be. And the other day, I looked in this data bank for state legislatures to see. It's early in the year, so a lot of bills haven't been filed yet. I was trying to get a sense of, is there a trend at the state level, and I couldn't see it yet because they're not all in session yet. Is there going to be a government? I mean, we're living in, the news cycle right now. Who knows what's happened while we've been here, right? I mean, we're living in an extraordinary times. But are any of you seeing, either at the state level, because there was some stuff done last year, but not a huge amount on this, are either of you seeing a surge, any of you seeing a surge at the state level to start addressing it, or is there something bubbling up in Congress that there's so much going on in Congress that, we haven't really heard that this is happening? Is government going to have a response to the outrage we saw in December?
I can start us off. And it looks like Ravi wants to jump in. So perhaps, right, I think to your point, there's some other things going on in the political landscape that might, push some of those concepts further back so that we don't see something immediate in the Maryland legislative session. There might be additional guidance coming out of the regulators, CMS, and other entities around it, but we don't have visibility to anything specific. Ravi?
Yeah, sorry to jump in at the same time. Joanne, I'm glad you brought it back to the trust thing. I think there's a few different forms of trust. One is the trust that the patient has with the health system and with their clinician and the role of the insurance company. Obviously, much more in display after the United killing. But also, like, there is a lot of real anger around denial of healthcare that is very clear. And then the other piece of this that I think is worth mentioning is the trust that is among clinicians in their employer or in the healthcare system at large, and in their role in being able to give the care that they feel is medically appropriate to their patients. And so I think there is some erosion of trust around that too, when clinicians feel like they have decreasing amounts of control over time in what their training has allowed them to do. And I think that there's a few different pieces to this. One is just the transparency piece that we've been talking about. And then the other is that it's a technological problem. It's a design problem that we should be able to solve through various forms. And so to your question about what are some of the legislative efforts or what are some of the efforts through, say, CMS, there's a piece of legislation that's been around since before the last few months that is bipartisan, because I think prior authorization or reform of prior authorization is one of the few bipartisan issues right now, but it hasn't really moved forward. And most of it has to do with streamlining the processes and modernizing processes for prior authorization, all of which I think is great stuff. This is what we've been talking about today as well. And then CMS has released a series of rules in the last couple of years around improving and streamlining and modernizing processes, reducing wait times, making more public disclosures, requiring plans to have more public disclosures around the clinical criteria that's being used to make these decisions. So I think a lot of this was
apply to
already
private insurer would that would just be for government plans for Medicare, Medicaid?
Yeah, so that's the issue. Yeah,
The commercial market's not covered by it. Okay.
I would certainly say I agree certainly with everything that's just been said on that, and certainly we've got a long ways to go. Trust is not simply going to be about prior auth or denials. Trust is so much broader and deeper. And as I said at the beginning, it's now a societal issue. What happened in that particular incident and the why and the reaction to it? There are so many awful, layers of the onion to peel back there and try to address. And we all need to come together and talk more about it and think about it. But I just would also say that it's absolutely fine and appropriate to be looking at what other requirements to put on plans, especially around transparency, interoperability, e-prior auth. Those are all very smart. But we also do have to, again, go back to providers that are still using fax machines, not actually, participating in this system in any way. And what are the expectations, the reasonable expectations and requirements on providers? It's got to be both sides here.
Amit, do you have a final question? Because we're about out of time.
No, I think I just wanted to thank the panel for an amazing conversation, and really big kudos to all three of you for championing this at a national level and impacting the lives of all our patients. So thank you so much, and thank you for such a candid conversation.
Thanks for having us.
Thank you.
Thank you.